Both short case. Lokia, 41-year-old male from Miralguda, who is an auto rickshaw driver. I took the history yesterday. He is the informant. History is reliable. Presenting complaint: increased lower limb swelling and breathless, shortness of breath for the 2 weeks. History of present illness. As the ongoing illness is a part of the disease continuum, I will date back my history 7.5 months back. Patient was in his normal health around 7 months back when he was on his regular BP medication with good control. He noticed hypertensive. That I will explain. He's a hypertensive for 2 years, madam. The details of the hypertension I will explain in the past history, madam. He was in his normal health on regular BP medications with good control. He noticed swelling of the both lower limbs around 8 months back. It was present up to the ankle, non-tender, not associated with any fever. He also noticed mild breathlessness, especially when climbing stairs and on exertion. No history of chest. Breathlessness on exertion and breathlessness on climbing stairs, madam.
Grading, that is grade?
Grade 1, 2, madam. 2. So, no history of chest pain, palpitation, orthopnea or paroxysmal nocturnal dyspnea. No history of decreased urine output, prothuria or hematuria he noticed at this point in time. No history of abdominal pain, distension, yellowy discoloration of the urine or the eyes. He consulted a local hospital after around one month of the onset of the symptoms because there was no relief. Symptoms remained the same throughout the period for that 1 month, except for increase in the pedal edema extension up to the mid calf. At the consultation at the local hospital, he was told that he is losing protein and blood in the urine, and also he has raised creatinine around 2.8 milligram per deciliter, and he was advised to undergo renal biopsy. He was admitted, given some IV injection, and underwent renal biopsy from the left kidney with no intra-procedural or post-procedural complications. At this point of time, he don't give any history of arthralgia, any skin lesions, any cough, any fever, any dysuria, hemoptysis, epistaxis. No history of alopecia, oral ulcers. No history of any analgesic abuse or indigenous medicine used during this point of time. After the renal biopsy, after 2 days of renal biopsy, he was started on Vicelon tablet 20 milligram per day, and he was advised to follow up after 1 week for further collection of the biopsy, total biopsy report, and further continuation of the medicine. But after 1 week after the hospital discharge, she stopped all treatment and he defaulted treatment, and he never followed up the doctor again. He had progressive increase in the symptoms with the increase in the swelling of the both lower limbs. Initially, it was confined to the ankle, but it progressively increased up to the mid-calf. His breathlessness also increased from the class 2 to class 3. He became NIHA class 3, and he also started experience abdominal bloating associated with the early satiety. At this point also, he don't give history of any decreased urine output or any facial puffiness, no prothuria or no other complaints. So he came for the first time to the NIMS after around 4 months of first biopsy in May 2023, where at presentation he lost all his previous records. He had no biopsy reports, and he was unable to retrieve that biopsy report from the first parent hospital. At presentation to NIMS, his creatinine was around 4.5 to 5 milligram per deciliter. The exact value he don't remember, and he was also told that he has loss of protein and loss of blood in the urine. So, as the biopsy report was unavailable, he was counseled regarding a rebiopsy and underwent a repeat biopsy from the left kidney under ultrasound guidance with no intra or post-procedural complication. After 2 days after the biopsy report, he was told that some changes are in the biopsy report and was given some tablet. The names he remembers telmisartan and Vicelon and mycophenolate mofetil, and he was advised to follow up after 1 week. After 1 week, he followed up to the OPD. He was asked to continue the same medication and asked to come after 2 weeks. He doesn't complain, and he lost to follow up, and he stopped all medications. And now, after 2 months of the second biopsy, he presented with increased edema extending up to the thighs, associated with the scrotal swelling, associated with the decreased urine output. He also now gives history of the his breathlessness has increased to the NIHA class 4. associated with orthopnea, and he also gives now history of decreased urine output. For the present complaints, he again revisited our hospital and found out to the creatinine around 7.8 milligram per deciliter, and he was told that he may require dialysis, and he was put on left femoral non-terminal catheter and initiated on hemodialysis. When I am examining the patient, he was first day after the dialysis, and he was symptomatically feeling better, and Sure, okay. No, madam, he doesn't quantify. He is telling that he will pass 2 to 3 times, but decreased compared to the last time. So fast history, man. On a routine health checkup at his village, he was diagnosed to have hypertension. Around 160 was the BP at the first time, 2 years back, and he was started on amlodipine 5 mg once daily. He never followed up again, and he was never checked the BP, but he has no complaints, any headache or any chest pain, nothing was there. He was continuing the medication. No history of diabetes mellitus, bronchial asthma, pulmonary TB or CAD or CV, cerebrovascular accident. Family history, he is fourth in order of a non-consanguineous married couple. Both parents are hypertensive. Elder sister is hypertensive and diabetes. No history of CKD in the family. Personal history, he is a chronic smoker and chronic alcoholic for the last 20 years. He stopped both around 3 months back. He used to smoke 4 to 6 cigarettes per day, stopped for the last 4 months. Chronic alcoholic, daily drinker, he used to drink around 2 quarters of brandy per day. In between, binge drinking pattern is also there. Drug history, he is on antihypertensive amlodipine with no proper follow-up.
You think his hypertension is something like a past history has no relevance to his present?
He has
Normally, what do we understand by past history?
Past histories which is not related to.
So his present presentation, his present problem, you think has nothing to do with his hypertension for the last 2 years?
Sir, maybe that hypertension was the index first presentation for the underlying kidney disease, which we may go.
Does it become a past history?
Oh no, sir, present is. I should have started with the hypertension.
Yeah, it's okay. It's a continuation of the
Presentation
disease.
2 years back. And possibly he has presented now.
If it was, very long history, say 10 years or something, then you could have on the website, maybe it was essential hypertension and this is separate.
Sir, examination, he was conscious oriented, pulse rate was 78 per minute in the right upper limb. BP is 160 by 100 in the right upper limb in sitting position. Pallor was present, no icterus, no cyanosis, no clefting. Pedal edema was present, extending up to the mid thighs. So abdominal wall edema is there, and head to foot examination was normal. There was no skin lesions, no alopecia, no oral ulcers, or no joint swellings. Chest, on systemic examination, chest examination, bilateral basal crepitations were fine. Except that nothing was there.
Cardiovascular system.
No, nothing was there, madam. Apex was palpated 1 centimeter medial to the midclavicular line.
Quality of effects.
Quality of the normal only, ma'am.
No
No
cardiomyopathy.
cardiomegaly.
So what is your final diagnosis? Abdomen, anything?
Abdomen, nothing.
These are not palpable.
Kidneys are not palpable, ma'am.
Diagnosis?
Ma'am, now he is CKD stage 5, madam, because he has
Stage 5 only?
dialysis depends. Stage
Stage
5
5D.
dialysis.
Stage 5D.
Mm.
Stage 5D, probable chronic glomerulonephritis, madam.
Mhm.
Index presentation at the
Only diagnosis. How do you
chronic
complete
glomerulonephritis.
diagnosis? CKD stage 5D.
Chronic glomerulonephritis,
Mhm.
native kidney disease. I would like to keep, madam, whether it may be IgA nephropathy, which has progressed to ESRD, or any membranoproliferative glomerulonephritis, which might have progressed to ESRD. Since there is no.
What is the KDIGO recommendation to put your diagnosis of CKD?
Madam, 3 months history of any structural or
No, how will you express your diagnosis of CKD? How should you express the diagnosis of CKD? What is CGA stage E?
Madam, CKD, according to the glomerular filtration rate and according to the albuminuria criteria, both we have to see, madam.
Okay, C is the cause of CKD. GFR stage and albuminuria stage. So CKD, what is GFR stage? You said stage 5D. Albuminuria stage?
Exact albuminuria we don't know, madam. Quantification.
Patient had proteinuria. Overt proteinuria is always A3, isn't it? Cause is possibly CGN. So CKD probably due to CGN, G5D and A3. That is your, as per KDIGO, your diagnosis should be like that. Okay.
A3 is how much?
More than 300.
Total protein or albumin?
Albumin, madam. Albumin excretion.
A3, okay. Why do you think this is CGN?
Madam, because the progression, first he presented with hypertension, then there was a hematuria was there, proteinuria was there, altered renal function was there, and there was proteinuria feature like edema was also there, madam, that is why. And also the glomerulonephritis.
The patient has proteinuria, hematuria, mild renal insufficiency and hypertension. These are the 4 components of chronic glomerulonephritis, okay, of more than 3 months duration. Great.
Then, madam, the disease might.
If you were the consultant with, when he diagnosed with hypertension 2 years back, what you should have done at that point?
Madam, it was he was 39-year-old at the time of the hypertension, madam. So whenever he was diagnosed to have a hypertension, we should have a basic blood investigations like whether any renal dysfunction is there or not.
All hypertensives should have a basic investigations of cardiovascular disease and renal disease. Agreed.
Madam, and we have to properly follow up the patient because whether there is any complaints,
If there are any suspicion of renal parenchymal hypertension at that point of time, what you should have done?
we should have done a complete urinary examination following which a renal dysfunction.
Urine analysis is a must for all hypertensive at first diagnosis.
We should have done a renal biopsy at that
At
point
that
of
point
time.
itself. At that point itself, isn't it? And what is the probable cause of CGN here?
IgA nephropathy, I will think, madam.
Okay.
One thing intrigues me. You said he had a re-biopsy
Yes, ma'am. Yes, sir.
and the creatinine was already 4.5 at that
That
time. And then he was put on Viceron and MMF. So how do you explain that?
Maybe that.
What should have been the reason for aggressive treatment at
That may be
4.5?
rapidly progressive variant of IgA nephropathy can
Presentic
be.
IgA.
What is the rapidly progressive variant? Can you send us
Presentic age. Any other reason for immunosuppression in spite of 4.5?
Madam,
In spite of 4.5 milligram
there will not
creatinine?
be significant IFTA in the biopsy. There will be not any chronic damage. Might be
Okay,
chronicity,
might not, the T score may be only T0, T1. And what are the other?
Some immune-related renal injury might be the
No. If it is IgA, what can be the other reason for immunosuppression at 4.5?
endocapillary hypercellularity.
Hypercellularity. M1E1. M1E1 T0 may be the histopathology in spite of 4.5 or crescents.
Or could it be something other than IgA?
Yes, yes, sir. The other, some other immune complex related glomerulonephritis is there. We can try with go with immunosuppression, and also.
So which one?
Like,
And which one will you do this combination?
You said he was given 20 milligrams per day.
Yes.
Was it by a nephrologist?
Yes, sir.
Do you think that dose was sufficient?
No.
So in which other condition you would give Viceron and MMF combination?
So the SLE in the induction phase. But in this patient, there was no other things were there.
Systemic disease to suspect.
Nothing was there. And also in some immune complex related glomerulonephritis, which is rapidly progressive and renal dysfunction, we will try with the MMF and steroids, sir. And also in IgA nephropathy, also steroids.
We don't really know the biopsy.
What do you think the reason for that progression from 2.8 to 4.5 and then 7 over a period of 7 months?
Rapidly progressive, if it's an IgA nephropathy, it can be a crescentic variant of the
It
IgA
can be a
nephropathy.
crescentic IgA even in the first itself. 1, 2.
Then other causes will be like, madam, if there is a macroscopic hematuria is there, that may cause in recurrent AK can happen, and sudden deterioration of the renal function can
Patient
happen.
does not any history of those
No
hematuria.
Those.
history.
What is most common cause of rapid loss of GFR?
Artery.
Uncontrolled
Uncontrolled
hypertension.
hypertension.
Uncontrolled hypertension. Oh. Okay. What are the other risk factors for rapidly worsening GFR in IgA?
Like madam, if the crescents, then the uncontrolled hypertension is there.
Uh-huh. Risk factors for rapid loss of GFR in IgA.
If there is if there is more if there is more proteinuria,
Proteinuria.
is there.
Yes, proteinuria more than 1 gram is the worst prognostic factor in IgA. Any other factors?
Factors that predict rapid decline will be more proteinuria, index presentation if there is a latency between the presentation, symptoms and the presentation.
There are specific points for assessing the prognosis.
So IgA nephropathy
Male
prediction.
sex,
Madam.
proteinuria at presentation, GFR at presentation,
Then diastolic BP and systolic BP at the presentation, madam.
hypertension,
And
hyperuricemia,
and raise black will have faster progression. IgA nephropathy prediction tool will predict at the
Okay.
time of the biopsy how much fast it will predict.
What are the various, how many factors are there?
13 factors are there, madam. So first one is the gender of the patient.
Okay. What are the histopathological factors?
Mesangial hypercellularity, endocapillary hypercellularity, segmental sclerosis, and tubular atrophy, madam. Crescents are not included in the prediction tool, madam.
Okay, good. Anything else in the histopathology? Immunofluorescence will predict that this is a bad prognostic IgA.
IgG.
Any importance of co-deposition of IgG, IgM or C3?
If there is co-deposition of the IgG and the C3, there will be
No.
no.
Anything else? Co-deposition tells you that this is poor.
IgM.
C1q, associated C1q, and capillary wall IgA deposits tells you that this is going to be a poor prognostic factor.
In IgA, is there some basic defect which is present right from even before the glomerular disease develops?
Basic. There can be genetic defect that can be there. Sir, underlying genetic defect is some genes were associated. Some HLA genes were developed, like HLA DQ-A1, DQ-B1, and DRB4 increases the susceptibility to the IgA nephropathy, and there will be a defective O galactosylation at the hinge region of the IgA will happen, sir. That will be the first hit, sir. Then there will develop antibodies against
So
this.
is there any non-invasive method of diagnosis of IgA nephropathy?
Galactose deficiency IgA can be
Serum level of Gd-IgA1 level.
So are there any new upcoming therapies?
Sir, initially the therapy was like we have to give 3 months of therapy of non-immunosuppressive therapy, like mostly AC and ARB. Now the new treatment options, non-immunosuppressive treatment option, there are SGLT2 inhibitors and like endothelin plus ARB are now recently been introduced. So DAPA,
What is that molecule?
Sparsentan and
Sparsentan.
Then that is a non-immunosuppressive therapy. So we can now give DAPA like SGLT2 inhibitors and also the anti-endothelin plus ARB inhibitors like.
Any other?
SGLT2 is only for slowing progression. No, it's not really a primary therapy. So what other?
Any other
Now,
newer drugs?
Newer
under
drugs
trial?
like BAF inhibitors, APRIL inhibitors, C3
Anti-APRIL antibodies.
sir.
And?
Then BAF inhibitors like blisibimod has been known in the, and then there's a trial like factor B inhibitor. Complement is finally mediating the damage.
Iptacopan.
Iptacopan.
Then anything else?
Like blisib.
We said it is the MBL pathway which is abnormal. So anything related to that? MASP2 inhibitors. MASP2 inhibitors. All these are under phase 2 trial now.
But anything else which is clinically now available?
Like locally releasing budesonide we can give, sir. Like it will reduces the inflammation at the local level and we can give, sir, locally.
Targeted
Release of budesonide.
now available, but we don't know how good it is. And what is the role of steroid?
Sir, steroids, we can, first initially we have to treat with a non-immunosuppressive therapy, sir. If there is proteinuria is more than 1 gram per day persisting after 3 months of this non-immunosuppressive therapy, we can start a trial of steroids.
Name the RCTs with steroids in IgA.
Sir, stop IgA nephropathy trials, testing 1 trial and testing 2 trials, 3 trials.
Testing low dose, not 1, 2. Testing high dose and testing low dose. Any other previous steroid protocols?
Like manoetrol and levoetrol.
Posis and Manos, Posis and Manos previous.
So what is now recommended, the low dose or the high dose?
Low dose, sir. Because in the testing one trial, what they have used was 0.6 to 0.8 milligram per kg per day steroids were used. They have to early stop the study because of the increased adverse effect. But they continued the recruitment with 0.4 mg per kg per day, and they found out to have there will be decreased proteinuria and decreased GFR decline associated with it.
If you see this patient at hypertension diagnosis, creatinine 1.5, proteinuria 500 milligram, how you should have prevented progression to this stage?
Aggressive control of the BP, madam.
Mhm.
And decrease-
Aggressive control means what?
less than 149, 130.
149 is aggressive?
No, madam.
Ah. What is the current KDIGO recommend regarding BP control?
120, less than 120/80, madam.
In CKD 120/80, KDIGO recommends 130/85 only.
Then decreases.
What are the drugs
Decrease.
for blood pressure control?
AC advice we can give, madam, because it will decreases the intraglommerular pressure also and decreases the proteinuria also, madam.
1, 2.
Then second one is calcium channel blockers we can give, madam.
Okay. Following what? Then what else? What any other drugs which can prevent further progression so that
Like some SGLT2 inhibitors and this
anything else? Proteinuria is still more than 500, 700, etc. Any other drug can be added. SGLT2 already said.
HCQ can be added.
CQ.
HCQ.
Role of spironolactone for antiproteinuric.
Yes. Second line we can add. So it's not controlled with ACRNP, we can add aldosterone antagonist.
Have they tried pindrinone for IgA?
Pindrinone is to decreases the hyperkalemia.
In which group of CKD this has been tried as Fidelio?
Diabetic patients with
Tried in diabetic kidney disease, not in primary glomerular disease.
Figaro.
Has there been some benefit with mycophenolate also?
Yes, sir. Mycophenolate classically tried in the Chinese population. There were Chinese population. So many studies are there, madam. They found out that MMF is useful. Now,
Some limited. What is the usual natural history of IgA?
it 15 to 20% progresses to ASRD in the next 10 years, and 20 to 40% progresses to ASRD in the next 20 years. That is what the natural progression.
Any difference in this progression in our population?
Our population has an aggressive, more rapid progression. Second case. Vincy John, 11-year-old female child from Warangal, studying in her 5th standard. The informant is both the parents and the child herself. Presently complained, she came to the nephrology OPD for the general checkup, as part of the regular checkup. I took the history yesterday. So history of present illness. As the presentation is a part of the ongoing continuum of disease, I will date back my history from the antenatal period itself. She is a second in order to a non-consanguineous parent. The antenatal period was uneventful. It was a booked pregnancy with no history of pregnancy-induced hypertension or GTM or any other complication during the pregnancy.
Is there any terminology of pregnancy-induced hypertension now?
Gestational hypertension.
Only preeclampsia,
Preeclampsia.
no pregnancy-induced hypertension.
Uh,
Better to use no hypertensive disorders during pregnancy. That will be more possible.
As per the mother, USG scans were done during the antenatal period and it was all told to be normal, and she was taking iron and folic acid supplementation during the pregnancy period. She was admitted at the term for the normal vaginal delivery, but it was changed to an LSCS because of the failed induction.
Any other antenatal history you want to elaborate? When you are presenting oligohydramnios, polyhydramnios, anything else?
No.
Any other history to be evaluated?
Are there any ultrasound, any antenatal hydronephrosis or
And
anything?
anomalies in the fetal and maternal history?
Preterm labor.
Okay. Any drug exposure during the antenatal period? Important? Maternal smoking, alcohol.
There was no history of any other drug intake during the pregnancy period except for the iron and folic acid supplementation. She delivered a normal child. She delivered by an LSC section. The child cried immediately after birth and passed urine immediately after birth. And birth weight, the mother remembers in between 3 and 3.5 kg. Exact value she don't remember. Child was apparently normal until 6 months of age with normal developmental milestones up to the age and was vaccinated up to the date. When her mother, one day mother noticed that there was an abdominal distension associated with a palpable mass over the abdomen, and on the same day the child started to have an incessant cry, and the mother also noticed her. She has been passed the urine for the last 6 to 7 hours. So she was immediately taken to the nearby hospital where she was catheterized and passed a large amount of urine. And after which child became playful and active and comfortable. After about 4 hours of observation in that hospital, the catheter was removed and was again kept in observation in the same hospital. But the child was unable to pass urine again even after feeding, and again the catheter was reintroduced. There was no history of fever or no history of vomiting or no history of the trauma to the local area during this episode. So she was the child underwent an ultrasound abdomen. 6 months. Child underwent an ultrasound abdomen at the local hospital, and the parents were informed that there was some mass which is originating from mass is there in the abdomen which is compressing the bladder, and she was referred to a higher center. At the higher center, she was evaluated with a further CT scan of the abdomen and MRI scan of the abdomen, and they were informed that there was some tumor that is emerging from the spinal cord and is approaching near the bladder, and she may need a surgery and chemotherapy, and she was referred to the oncology center for the further management. During the whole period, she was on catheter. She was passing a normal amount of urine with no blood or blood clots, and she was playful. After around 1 month of extensive evaluation, pre-operative evaluation, she underwent a surgery at cancer hospital, and after about 3 weeks of the surgery, the catheter was removed, and the child was able to pass the urine. Child was passing the urine in the diapers. But after 3 weeks in the next hospital visit, she was told, after some blood investigation, the mother and father was informed that there is some tumor is remnant in the remnant, and she may need chemotherapy. So 6 cycles of chemotherapy was done at an interval of 3 weekly period. So after about 6 months of the onset, around 1 year of age, she was told that the treatment part is complete, and she have to undergo regular follow-up at 3 monthly interval. The child was passing normal urine at the discharge of hospital. She was passing daily 4 to 5 episodes in the day, and night also 4 to 5 episodes. The parts was stopped with the urine. There was no bladder control at that. She was only 1 year at the time of the discharge. She was on regular follow-up since then, and at the 2 years of age, during the routine USG scan as a follow-up visit, the parents were informed that there is, even after the passage of the urine, there is significant amount of urine is remaining in the bladder, and she needs extensive evaluation and further treatment. After extensive evaluation, as per the mother history, likely urodynamic studies, she was told that significant amount of residual urine is in the bladder after micturition, and how to use some tablet and clean intermittent catheterization. The parents were trained regarding the clean intermittent catheterization and asked to follow up. But the parents doesn't complain, and they went to another hospital, and that hospital they were told that there is no need to undergo clean intermittent catheterization. Every 2 hourly they have to apply pressure over the abdomen so that the urine will be voiding, and that should be continued. For the next 3 years, the parents was doing that only. She never achieved a urinary incontinence. Every 2 hours on a timely basis, they used to press on the abdomen, and the child used to pass urine. The next presentation to our hospital was at around 5 years of age, when she developed fever associated with the chills and rigor and burning. There was dysuria associated. Asking regarding the parents or the symptomatology that time, she was 5 years at that time. She never attained even daytime continence or nighttime continence. She never attained. the parents were using the timely manner of emptying the bladder, and at night time they used to put the pad, and in the morning hours it usually get to soaked with the urine. So again, she was treated with IV antibiotic. After the complete treatment period, again the battery of investigation was repeated, probably urodynamic studies, and she was asked to continue clean. The parents were tried to continue counsel regarding continuation of the clean intermittent catheterization. The parents were doing, that time one infection was there, madam, that was treated with antibiotics. So from the 5 years of age of the child, they are the parents were are doing clean intermittent catheterization and using sulfenazine tablet at the night time. They are doing it daily around 5 to 6 times per day of catheterization, but less frequently on the school days. When now she is going to the schools on the school days, she always had to wear sanitary pads in the daytime and the night times. The mother noticed never attained. She never attained to bladder control, and for the last 2-3 years the child is telling that she is having increased frequency of urination. He is getting sudden unexpected compelling desire to void, but she is unable to hold the bladder until he reaches the toilet, and he is the soiling the pads and soiling the clothes.
What do you call that?
Argent continence, ma'am.
Can use those terminologies.
So after every voiding, when she is at the home, she has to strain at the toilet for the urination.
Whether you just got
After
into
clean intermittent. So for the in the last 6 months during her urology visit at the hospital, she was told that her creatinine is 1.3 milligram per deciliter, and she needed nephrology follow-up, sir. And from
What age?
10.5 years. Since then, she is on regular follow-up with the nephrology department. She is currently using a tablet called Nodosis and sulfenazine tablet, and she is using clean intermittent. Parents are using clean intermittent catheterization also. On examination, madam, she is moderately built and well nourished, conscious, coherent, and cooperative, afibrate. Height is 132 centimeter within 2 standard deviations of her age, and weight is 34 kgs. BMI is 19.5 kg. A curvilinear scalp present over the lower abdomen below the umbilicus, and also a vertical scar is present over the lower back parallel to the spine. There is no dimple, no tuft of hair or anything is there present over the lower back. There is no spinal abnormality or no gait abnormality. Her pulse rate is 90 per minute, and BP is 100 by 60 mg in the right upper limb standing position.
Any evidence of rickets?
No, nothing. 100 by 100. No rickets. No. All development milestones are attained to the age. She is now studying in the 5th standard, and she is having a good scholastic performance also.
Bladder is palpable now?
At the time of the when I am examining, madam, she already was past urine and she was catheterized.
Have you examined her external genitalia?
Madam, I asked for the consent, but she
Okay.
were not comfortable.
You have to look for external genitalia, hernial orifices, anal orifice, etc. was to be looked up if you are discussing a lower urinary tract problem. Okay. So what is your diagnosis at this point?
No rickets. She is well built and with no other.
Diagnosis is plus minus. Anything related to TAM protein related pathogenesis mechanism?
Obstruction. Intratubular.
It can produce cell injury, damage to the basement membrane. TAM protein goes into the interstitium, and you develop antibodies against that. That is also one of the pathogenic mechanisms. Okay. Now, why she has no rickets? Do you expect rickets in this girl?
Yes. Like if it's a chronic injury, there can
This
be.
is since antenatal, 6 months of age. This, how do you explain rickets in this girl?
No rickets.
No rickets in this girl.
Renal damage. Less renal damage. Renal damage might be.
Now, can a girl with an obstructive nephropathy can have rickets with a normal GFR?
Yes.
Explain. It is not due to renal osteodystrophy, GFR is normal. Still develops rickets. Very
Why?
common for pediatric
Why do you
obstructive uropathies and nephropathies, isn't it?
There will be concentration defects will be there, madam. So,
So? There will be volume depletion, natural urosis, that's all.
then some tubular reabsorption is not proper. There will be hypercalciuria and hypermagnesiuria can have.
What is that?
Defect.
Tubular defect leading to what?
Proximal tubular disc. Renal tubular acidosis.
Renal tubular acidosis. They are prone to develop renal tubular acidosis. Why they develop renal tubular acidosis in the early stages?
Distal. It can be either distal renal tubular acidosis or proximal renal tubular.
Usually what?
Distal renal tubular acidosis.
Why they develop the distal RTA?
Due to this, the obstruction, this back pressure.
Functional derangement of the abdominal duct plus ATPase. So they develop functional renal tubular acidosis. Early stages of pediatric CKDs are usually normal anion gap because of RTA. Then they go into a hybrid type of acidosis and CKD progresses, goes to a pure high anion gap acidosis. Very common, isn't it?
What is this, what is the tumor that was removed because in the spinal cord?
Sir, it was a sacrococcygeal teratoma only, sir.
Or it can be meningomyelocele also.
Meningomyelocele.
Meningomyelocele.
That's more common.
More common.
So the difficulty in voiding was not the direct effect of the tumor on the bladder. It must have been a neurogenic bladder right from
Right, sir.
because the way you presented it, you said the parents were question is must have been
Neurogenic bladder itself.
problem right from the baby. The growth of this child is also normal.
Normal, sir. Normal, sir. She is in par with her age group, sir, and it's in the 2 standard deviations. She's looking perfectly normal with.
What is the nerve supply of the bladder? Normal nerve supply.
Sir, bladder is supplied by the somatic nervous system and the sympathetic autonomic nervous system, sir. The sympathetic nervous system is from the T11, T12 and L1 and L2 segments, and the parasympathetic from the S2, S3 and S4 sympathetic system. So what happens from the this T1 to L2 segments, sympathetic nerves which emerge, which is the inferior hypogastric nerves, sir, which will form a plexus, and from the plexus it will innervate both the bladder and it will be the internal urethral sphincter, sir. In the bladder it will be like beta 3, and in the internal urethral sphincter it will be the alpha 1, and the parasympathetic system which will be arising from the S2, S3 and S4, which will make a plexus in the pelvic plexus, and it will innervate the bladder, and it will be M3 receptors, muscarinic M3 receptors, sir. And the somatic nervous is supplied by the pudendal nerve, which supplies the external urethral sphincter by the nicotinic receptors, sir.
Which nerves are more important for emptying of the bladder?
Emptying of the bladder, there should be a coordinated detrusor contraction associated with the sphincter relaxation, sir. So parasympathetic system, like parasympathetic system, and the relaxation also should happen, sir.
What drugs can improve the diffuser contractility?
Detrusor contract to increase the detrusor contraction. To increase the direct contractility, we can have cholinergic agonists, sir, like a beta-anacol, and beta-anacol we can use, sir. And also to relax the sphincter, we can use the alpha-1 blockers, sir, like tamsulosin and alpha-succinol blockers. We can.
What is you said this child was on solifenacid.
Solifenacid.
What does that do?
Sulfasalazine is an anti-muscarinic agent, sir. Whenever we are suspecting a detressor hyperactivity, we have to decrease the hyperactivity. So anti-muscarinic agents we can produce. Initial anti-muscarinic were non-selective, sir, which are used to block all the muscarinic receptors. That is the oxybutynin and fluvoxamine and tolterodine. Now the new generation selective M3 receptor antagonists are comes, sir. That is this sulfasalazine, sir.
Any other?
Tolterodine also. No, Darifenacin is there, sir. Tolterodine is actually.
Any other drug that is used for an overactive bladder?
Botulinum toxin we can give, sir.
That is injections. But any other tablet?
Beta 3 agonist we can give, sir. Mirabegron we can give.
The urologist uses it very
If this child has gone into CKD G5, how will you evaluate her bladder before transplant?
Madam, any patient with a bladder, neurogenic bladder who is going for a renal transplant should have an extensive
How do you do?
Madam, we can do with the uroflowmetry, we can do non-invasive and invasive tests are there, madam. Non-invasive tests are post-voidal residual urine and the uroflowmetry, and in the invasive test we can do a pressure flowmetry with storage, filling and voiding phases, and video urodynamic studies with the fluorometry to look for the VUR.
It's a very low capacity bladder after evaluation. Can you do anything pre-transplant?
Augmentation cystoplasty we can do, madam.
What is the procedure
Ideal
usually?
loop you usually use, madam.
If the patient has a grossly dilated ureter,
We can use the ureter
that is
itself,
the
madam.
best to have a augmentation cystoplasty.
What is the commonest manifestation of rickets? If this child had rickets, what would be the first thing you would look for?
Skeletal abnormal.
Which one?
Flying of the
More
pubic
obvious.
pes
Lower limbs.
where the she handles the weight, it will come into pes varus will come. Valgus.
Genovalgus.
Valgus.
Commonest things.
Genovalgus.
How you define that as genovalgum?
The intercondyle diameter we have to
More
calculate.
than distance, more than
Intermalleolar.
Normal.
genovalgus, varus, intercondylar distance. That is specific measurements to say that there is valgus or varus deformity.
If such children have growth retardation, can you do something?
Growth hormone therapy we can give. If there is we have to see regarding the bone fusion. If the bone fusion hasn't appeared, we can try with a growth hormone supplementation.
Are you interested to see her acid-base status?
Yes, madam. Like chronic, if there is a renal
Initially she will have normal
Normal
anematocytosis, then will have high acid.
like,
So, why you are interested to see the metabolic acidosis part?
it will increases the
What should be the target bicarbonate?
like more than
20?
24 should be there.
Your definition or your definition or? Huh? What is the latest KDIGO says? It should, initially it was, last KDIGO it was 22, isn't it? Target was 22. Any change in the recent?
Up to 17 can.
More than 15 is sufficient. More than 15 is sufficient. How this, why do you want to keep the bicarbonate to normal?
Because when there is acidotic milieu is there, there will be increased resorption of the bone and all this will happen at the
To
bone.
prevent bony injury. Two,
The progression of the renal failure will be more with the
how it produce progressive loss of GFR mechanism.
Free ride.
Any other organ? Cardiovascular.
Cardiovascular.
So these are 3 organs where you are interested. Injury happens to. Does it cause any influence on growth of the child?
Yes, ma'am. Growth retardation will have.
How?
Acidotic milieu.
So metabolic acidosis and its benefits of treating metabolic acidosis.